Hello Falava everyone, and welcome back to the first of the Goodfellow Unit Webinar series for 2024. Tonight's webinar is on respiratory infections in children, and my name is Dr. Hazel Fuyava. I'm a GP in South Auckland and I work for the Goodfellow Unit. We also will hear tonight from Doctors Cameron Grant and Aaron Oy. So Cameron is a general paediatrician at Starship Children's Hospital and a professor and head of the Department of Paediatrics and of Child and Youth Health at the University of Auckland. His research focuses on prevalent child health problems, which cause disparities between population groups in New Zealand and strategies to eliminate these disparities. Aaron is a general paediatrician with an interest in developmental and behavioural paediatrics based in Rotorua, New Zealand. He is also an honorary senior lecturer at the University of Auckland and has strong interests in medical education, research and quality improvement. I will now hand over to Cameron and Aaron. Thank you.
Karere aku mihi ki na iwi o mahuhu, ki te rangi waka, me na mata waka o te motu. Tēnā koutou katoa. E te hui, whaia marama, kia whaitake na mahi katoa, tua maia, tu kaha, aroha atu, aroha mai, tātou ia tātou katoa. No kotirana oku mātua tupuna. He Pakeha aho, I whanama aho ki o Tautahi, I tipu ake aho ki o Tautahi. Kei tamakima karara aho e noho ana. He takuta tamariki aho, he takuta ahorangi aho, ko Cameron Grant, toko ingoa, tēnā tātou katoa. Aaron and I have three presentation aims this evening. We want to help you to be able to identify the acutely unwell child, provide you with some clinical pearls for common respiratory infections, and then conclude by providing an update on preschool wheeze. I'm going to stop sharing now and pass on to Aaron.
Oh, thanks, Cameron. Tēnā koutou katoa, ko Maria te whakapaparanga mai, ko Wakato te whunga tupu, ko Rotorua te kainga, ko Aaron Oy toko ingoa. Tēnā tātou katoa, kia ora everyone, my name's Aaron. So when we asked who was attending today, we understand that we've got quite a range of attendees, from those who are GP 1 to very experienced GPs and nurse practitioners. So I thought we're going to start off with a little bit of the basics and then try and build on this as we try and cater to everyone's level as well. So as Cameron alluded to, I will be covering the first two topics, so identification of the acutely unwell child, followed by some clinical pearls for common respiratory infections, and hopefully provide some useful resources along the way. And we'll have some Slido polls too, so please do participate as we go. So part one, the acutely unwell child. Often when we have juniors start in pediatrics, we tell them that a significant chunk of what we see in pediatrics is breathing and feeding. So I thought just to start off with, we can briefly go through these basic questions. So what are your clinical signs for increased work of breathing? Which are the more severe? And also consider specifically the relevance of phases of respiration when assessing a child and how that might impact on our differentials in a formulation. If I can get some responses, please. Just to start off with, it's not a trick question, basically looking at what are your clinical signs for increased work of breathing? Just start off easy. Yep. Anything else? You can pop down more than one answer. Recessions, yeah, so subcostal, intercostal recession. Yep. Accessory muscle use. Yep. Tracheal tug, head bobbing. Yep. Audible sounds, nasal flaring. Excellent. Anything else? Prolonged expiratory phase, respiratory rate. That's excellent. Lethargy, grunting. Yeah. Yep. That's perfect. Circulatory compromise, stridor. Excellent. So yeah, those are also common signs of increased work of breathing. So now that we've established our assessment as to which signs are present, we often want to get severity as well. So which of the which of the previously mentioned signs of increased work of breathing are the most severe? And what we're hoping to gather from this is that ideally it's not as discrete as such, as much more of a spectrum, but it's more a sense of what are the more severe signs compared to the ones which are more mild. Let's give that a bit of time. Also, it's a bit of a mix. So the way I think about it is often a lot of the kids that we see will have subcostal, intercostal indrawing and tracheal tug as well. But actually, if we're seeing nasal flaring, head bobbing and grunting, that would suggest a much more severe presentation, as we're needing to recruit accessory muscles and try and split the ear open to provide some positive end expiratory pressure. So I always tell my juniors that, if we're seeing a kid doing this, I'd be worried. Tachypnea is an interesting one. So often in the first sort of initial phases, you might see a bit of tachypnea. And then after that, they might become quite lethargic and labored in their breathing too. So basically head bobbing, grunting, nasal flaring, anything above sort of where you're using accessory muscle use is a bit more severe. So one of the things that I also always teach the juniors is looking at how the relevance of the phases of respiration affects your formulation and your differential. So as we know, the inspiratory phase is usually longer. And so if we do have a prolonged expiratory phase, then that might give you clues as to a more obstructive picture along the spectrum of bronchiolitis, preschool wheeze, or asthma. And I often get our students to incorporate that as part of the assessment of work of breathing as well. So, for example, if you've got a case of something like, you're wondering whether it's a bronchiolitis versus a pneumonia, we don't generally see a prolonged expiratory phase in cases of pneumonias unless it's atypical. So something like mycoplasma might give you a bit of wheeze, but in general, bronchiolitis, preschool wheeze, and asthma is more associated with a prolonged expiratory phase as part of your assessment. So we said that pediatrics is breathing and feeding. So what about your signs of dehydration? So what are your clinical findings for signs of dehydration? Weight loss, yep. Hypotension as a late sign, great. Cap refill, dry lips, mouth, mucous membranes, foreskin turgor, sunken fontanelle. Nice, cool. Just a good one to mention is also weight being the gold standard of fluid status as well, particularly in kids with gastroenteritis. It's often useful to know what discharge weight and pre-admission weight is. Yeah. Tachycardia, sunken eyes. Excellent. Reduce level of consciousness, reduce urine output. Yeah, dry nappies. Perfect. Yeah, I think that covers all of our signs actually. And so again, when we're looking at our clinical signs as well, we always want to think about how severe it is. So again, it's asking you to rank, and I know it's not as discrete, but if which ones are the more severe signs of dehydration? Sort of looking at the ends of two spectrums. Yep, hypotension is a very late sign. Cap refill as well. Reduced level of consciousness. Sunken fontanelle. Yep. Nappies, reduced tears, tachycardia, dry mucous membranes at the bottom. Yeah, excellent. Yeah. So yeah, you guys got a good sense of what is severe and what is the common stuff that we see in terms of mild signs of dehydration. Definitely hypotension and altered mental status is more on the severe end. Cool. Yeah, so we always want to think about severity. And so when we're looking at signs of dehydration itself, this was the seminal paper published back in 1997 from the Journal of Paediatrics regarding the clinical signs of dehydration. It was a prospective cohort study of children ages 1 to 5 years, about 186 kids or so, where they looked at 10 findings. So they looked at reduced skin turgor, central cap refill, general appearance, absent tears, abnormal respirations, dry mucous membranes, sunken eyes, abnormal radial pulse, tachycardia, and reduced urine output. And essentially, they found that any individual finding itself was a terrible predictor of dehydration, but a combination of signs was the most reliable. And they created what they call the clinical dehydration scale, which were 4 signs together that was diagnostic as to the severity of dehydration itself, and that consisted of cap refill, dry mucous membranes, abstinence, and general appearance. And this was actually validated against weight, which we know is the gold standard for fluid status. And this is the scale that they came up with based on general appearance, the eyes, mucous membranes, and tears, and essentially looking at the degree of dehydration with no dehydration, some dehydration, and moderate dehydration. There's you'll often see this quoted in some of the guidelines. So now that we've talked about breathing and feeding, wanted to focus sort of putting it together a little bit and identifying risk of serious illness in children with a fever, particularly under 5. And BPAC actually has a really nice traffic light system that can be utilized that I just wanted to bring your attention to. So this is the traffic light system from BPAC. It looks at 5 components. So skin appearance, responsiveness, respiratory, hydration, and other, and sets out what is deemed as low, intermediate, or high risk. You have the QR code from the previous slide. I won't go into the details, but essentially, in addition to breathing and feeding, skin appearance, and responsiveness, they also have a really nice section on other high-risk factors. So things like age, non-blanching rash, bulging fontanelle, neck stiffness, status epilepticus, focal neurological signs, focal seizures of vomiting. That's kind of like a nice red flag reminder of things that would prompt you to refer to pediatric medicine. When RMOs start on pediatrics, it's often quite tricky to remember vital signs because vital signs obviously change with age. And this is the on the QR code is the normal ranges from the Don't Forget the Bubbles website. I also find the APLS reference range is quite helpful too. What I usually tell my juniors is that my general rule in terms of numbers to remember for a 1-year-old is that their weight is usually 10 kilos, and their respiratory rate, if it's above 60, that's worrying, and if the heart rate is 160, that's also worrying. So those are the 3 numbers that I remember in my head. Obviously, we're always happy to answer calls. We talk about referring when we're unwell, when we're concerned, or we're wanting more observation. But these are also the other instances that we would get our juniors to accept referrals for, accept calls for advice for. We want to know particularly if a child has a fever and if they're under 3 months of age. So we'd say call PedsMed for that. If a fever is going on for more than 5 days, then we would also like to know about that. If there is a non-blanching rash, then do call PedsMed. And I always sort of reiterate the idea of being aware of the child with unexplained tachycardia. So a lot of the kids that we see will be tachycardic for one reason or another, whether that be a fever or they've just cried or that we've just done their bloods and they're upset. But I would always say be wary of the child that is tachycardic without a clear reason. And often we want to find the reason itself, whether that be are they dehydrated, have they got sepsis that's brewing. So in the absence of a fever and distress, I would say beware of the child with unexplained tachycardia. For those of you who haven't done very much PEDS or want a refresher, there is a sick child course as well out from the UK. It's about 8 hours of content of video and quizzes. It's based on the NHS guidelines, and would recommend that if you're wanting more resources or more education. So just to recap part 1, so we've talked about the acutely unwell child, we talked about breathing and feeding, and also severity. We've touched on the traffic light system that's available, gave you some resources for vital signs and normal ranges and general principles of when to call as well. So part 2, we're just going to briefly touch on some clinical pearls for common respiratory infections in the next 10 minutes. Just 1 or 2 learning points or things that we can take away for each of these topics. So acute otitis media, croup, bronchiolitis, asthma, and chronic cough. And again, we'll give you some resources along the way as well. So one of the questions that we often get asked is, what's the evidence for administration of antibiotics in acute otitis media? And in this instance, we have a lovely Cochrane review that was actually published in 2015. It's a widely quoted review, but essentially the evidence for antibiotics in otitis media most benefit in children under the age of 2 and bilateral acute otitis media, or if there's a discharge. Interestingly, the treatment goal is actually 1 day of reduced pain, so it doesn't actually alter the course of the illness itself. And if we look at general numbers in pediatrics, the number needed to treat is 1 in 20 to achieve that treatment goal, compared to a number needed to harm of 14. And often you might see vomiting, diarrhea, or development of a rash. But if we look at children under the age of 2 with bilateral acute otitis media, the number needed to treat is actually 4. And under the age of 2 with a discharging year, it's actually number needed to treat of 3. And obviously, antibiotics of choice is amoxicillin in this case. One of the other questions that we get as well, specifically for croup, is, does it matter if I use prednisolone versus dexamethasone? There was randomized controlled trial, and essentially there's no difference. Dexamethasone does work longer, but if you're stuck and if you don't have dex, then prednisolone is a very acceptable alternative. Switching gears to bronchiolitis, just wanted to draw your attention to the Australasian bronchiolitis guidelines as well. It's for children age 0 to 12 months. It does say that it can be used in children over 12 to 24 months, but they acknowledge that there's often diagnostic uncertainty within this 12 to 24 month age group. Obviously, bronchiolitis is a clinical diagnosis based on typical history and examination, where there is history of symptoms of an ERT, which then progresses to develop lower respiratory airway signs. But essentially, one of the take-home messages from this guideline is that chest X-ray, blood salbutamol, steroids, and antibiotics aren't routinely indicated. And that's the QR code there that will take you to the guideline if you're interested. In terms of asthma guidelines, so we've got the New Zealand asthma guidelines that's available from the Asthma Respiratory Foundation. That's the QR code there. I think one of the key questions that we often get is, in terms of treatment, consideration of the age and type of inhaler device, and they've got a really beautiful approach towards that in the guidelines itself. I think it's also useful to know when in our corticosteroid preventer. And I think one of the things that's quite marked in pediatrics is that there's no role of a long-acting beta agonist without the use of inhaled corticosteroid, because studies have shown that that's been associated with increased mortality if we do that in isolation. At every asthma visit, we would check on control, adherence, technique, symptom diary, action plan, and also plan a follow-up. And there's actually quite a few action plans available. So there's the My Asthma app, and as well as that, the Child Asthma Action Plan from the Asthma Respiratory Foundation. And there's also the Starship guidelines. One of the things that we always encourage is thinking broader. It's amazing what a warm and dry house can do for our kids with current respiratory infections. So that's the Warmer Kiwi Homes tool that you can use. And finally, just wanted to touch a little bit about chronic cough and sort of look at these two questions. So the first one is, how do you define a chronic cough? And secondly, how do you actually ask about a chronic cough? So looking at the first question, so chronic cough can be defined as a daily cough for greater than 2 weeks, greater than 4 weeks, greater than 3 months, greater than 6 months. Take your pick. 3 months. If we look at the chronic cough guidelines, based on Starship, the definition is actually a daily productive cough that is greater than 4 weeks in duration. So that is how a chronic cough is defined. And one of the things that I just wanted to touch on was, how do we actually ask about a chronic cough? And I think this is particularly relevant in winter with where you see kids with recurrent back-to-back infections. And often when you ask families, do they cough every day or are they sick all the time? They'll often say yes. But what we're really wanting to know is that between these viral infections, do they have any days in which they do not cough at all and are cough-free? So often I'll say something along the lines of, we know that, little Johnny is having back-to-back infections at the moment, but what I'm looking for specifically is between these infections, are there any days, even if it's just for a few days, 2 or 3 days, where there is no cough at all? And then we're aware that he catches a new bug, but is there a period where there's no coughing at all in between these infections themselves? And often they might go, maybe. And so just getting that clarity of whether there's any cough-free period in between viral infections can be helpful in ascertaining as part of a history for chronic cough. Because if they are cough-free in between episodes, then it sounds like it's probably just back-to-back infections. But if they're having a persistent daily cough that we've ascertained, then we obviously want to think about assessment and management further. And obviously the thing that we're wanting to prevent is bronchiectasis in high-risk populations. There is a really helpful chronic cough starship guideline. Not expecting to see most of the flowchart, but it's just to say that it's there. And it does give you red flags as well, and an approach towards taking a history and assessment of a chronic cough itself. Essentially, if there is persistent cough, and you've excluded all the red flags, then we consider, and if chest x-ray is normal, then we think about something called protracted bacterial bronchitis, for which we would then treat with a 2-week course of antibiotics. And we would say that in that instance, then once you've done a part of a workup, that in terms of thinking when to refer to pediatric medicine, we would say, refer definitely when the chest x-ray is abnormal. If after 14 days of antibiotics, the cough persists, and then you've considered another 14 days of antibiotics, that cough still lingers, or if there's more than 3 recurrences of protracted bacterial bronchitis in a year, if the cough resolves following treatment. So if the cough resolves and the chest x-ray is normal, then we diagnose protracted bacterial bronchitis and we treat any recurrences with antibiotics itself. So that was a bit of a whirlwind just through some common respiratory conditions. So we touched on acute otitis media, croup, bronchiolitis, asthma, and chronic cough.
And we will certainly have some time at the end. Thank you very much. So the third topic we're going to cover this evening is an update on preschool wheeze. Preschool wheeze is the most common cause of preschool hospital admissions in Australia and New Zealand. And this slide here shows that we have over 3,000 children admitted to hospital in New Zealand each year with preschool age children with wheeze. Wheeze is such a common symptom in young children. Almost half of all children experience at least one episode of wheezing by the time they're 6 years old, and virtually all of these episodes follow a respiratory viral infection. And it's one of the leading causes of presentations to emergency departments and hospital admissions in Australia and New Zealand, as I mentioned, but really around the whole world. And it really is important to understand that the preschool age group is the age group in which the largest burden from wheezing illnesses is now concentrated amongst children. You can see that both in comparisons of admissions and of emergency department visits and of outpatient appointments, with the biggest differences being in hospital admissions. Preschool wheeze is an inequitable disease in New Zealand, as all respiratory infections are in children. And this project, which was an audit of hospital presentations to Waitakere Hospital and North Shore Hospital over a couple of years, demonstrated the higher rate of presentation for Māori versus non-Māori, and perhaps even more concerning that the risk of readmission within the 12 months of the first admission with preschool wheeze was almost double for Māori compared to non-Māori, and almost a third. Wheeze is a really expensive illness for hospitals, but it's also an incredibly expensive illness for the children and for their whānau. It has all sorts of costs, the cost of disturbed nights' sleep, the cost of visiting a hospital, and of all the costs associated with that, with transport and parking, the struggles of trying to work when you've had many nights of broken sleep, and the concerns about missing out on work through using up all of your leave as you care for your young child with this recurring problem. The current medicines that we use to treat preschool wheeze are those that are used to treat asthma. But this is despite the pathophysiology of preschool wheeze differing from that for asthma, and hence, not surprisingly, these medicines are not particularly effective. If we start with short-acting beta agonists, usually well tolerated, but we certainly see children who've had many doses of these and who become quite symptomatic with side effects, tremulous and agitated, and really quite upset. Short-acting beta agonists have not been shown to make any difference to the risk of being admitted to hospital. They have been shown to reduce the duration of emergency department stay, but only by about 30 minutes. Inhaled corticosteroids, a medicine that are also commonly prescribed in this age group, and the evidence for their benefit in preschool-age children is much less than it is in older children, and really driven by mostly studies that have enrolled children with persistent rather than the more typical intermittent symptoms of preschool wheeze. And there have been systematic reviews which have shown some benefit, but really only in those who are the smaller proportion of these children who probably have asthma rather than the more typical intermittent wheeze of preschool wheeze. And probably our greatest concern about these medications is their potential effect on growth and on body mass. It's very hard for young children to get much of the inhaled medication into their lungs. Most of it they swallow, and there's well-documented dose-dependent reductions in linear growth if young children are taking daily inhaled corticosteroids, and an increase in body mass, with the preschool age group appearing specifically vulnerable. And in a country like New Zealand, which has third or fourth highest prevalence of childhood obesity, we really do have to look at all the things that contribute to that, and particularly look at the things that we do that might be causing harm in this way. Oral corticosteroids, short course of these really makes no difference to symptoms in the shorter or longer term. But again, there's a risk of osteopenia if you have more than 4 short courses in a year, adrenal suppression, and also potentially hypoglycemia. And the other medicines that we sometimes use for asthma have really been shown not to have any role at all in preschool wheeze. And lastly of concern is the propellants that are used for the short-acting beta agonists and the inhaled corticosteroids are really harmful things. And there's a lot of concern about these globally, and quite an initiative from the World Health Organization for us to try and reduce the use of beta-dose inhalers. The propellants in these inhalers have global warming effects that are almost 4,000 times greater than that caused by carbon dioxide. So now I want to talk to you about a project that we're doing to try and address some of these issues that we have with preschool wheeze, and this is called the ARROW trial. And this is a study where we're assessing the reduction of recurrent admissions using OM85 for the treatment of preschool wheeze. It's a multi-center randomized double-blind placebo-controlled trial. And we're conducting this trial in New Zealand and in Australia. We've been recruiting in New Zealand at Starship, Waitakere, Kids First, Waikato, Tauranga, not yet in Christchurch and Dunedin, and also at a number of sites in Australia. And the intervention for this clinical trial is a product called OM85, which is a bacterial extract. It's a lysate made up of strains of bacteria from 5 separate genera, strains of a wide range of respiratory pathogens. And OM85, when taken orally, goes to your Peyer's patches, where it modulates immune cell production and improves respiratory defense against viral infections, and reduces the amount of mucosal inflammation you develop in your respiratory tract following a viral infection, and hence reduces the symptoms from that infection. It's been used in Europe for 3 decades, been given to over 90 million patients, almost half of whom were children. A safe product with some very mild and self-resolving symptoms of some gastrointestinal complaints, a little bit of cough and rash, but really not differing much at all from that seen in placebo comparisons. Good evidence from systematic reviews that it reduces recurrent respiratory infections and that it reduces wheeze episodes, but can it prevent healthcare visits, and in particular hospital admissions? Hence the ARROW study, in which we are determining the efficacy of OM85 for the prevention of hospital admissions due to an acute wheezing illness over a 12-month period in preschool-aged children with recurrent wheeze compared with placebo. It's a randomized, double-blind, placebo-controlled trial. We're enrolling children who are aged 1 to less than 6 years, who in the preceding 12 months had had 1 hospital admission with wheeze lasting greater than 6 hours, and have had at least 2 other episodes of wheezing or whistling in the chest or breathing out lasting greater than 6 hours associated with laboured breathing. The medicine's given orally. It comes as a powder in a capsule. The capsule can be opened and dissolved in a liquid, and it's taken on the first 10 days of each month for 12 months. Our primary outcome is hospital admission due to a wheezing illness in the 12 months following initiation of the child in the study. We've got a number of secondary outcomes, some of these related to the hospital admission, some related to wheezing episodes at home, some related to those impacts on the family, and also looking at the quality of life of the child and at anxiety, which we think might be a significant contributor to wheeze in this age group. We've developed a video which you can link to from this little barcode here. If you do link to it and watch it, please, if you enter the child's name, enter something like test. Otherwise, we're likely to follow up to you with more requests to make contact with you. But you're most welcome to share this with anyone. I have this on my phone and just share it with families in the hospital, and gives them a chance to watch the video and then decide for themselves what they'd like to do.
So we have a number of clinicians working, doing virtual work as well via telehealth. So we have a question here about telehealth consultations with parents of children with ear pain, and the parents are concerned about an ear infection and usually requesting antibiotics. So do you have any wisdom or pearls for us in terms of navigating that kind of consult? Obviously, we don't want to just dish out antibiotics to everyone, but we can't examine the child, so that's a bit tricky.
I think that you guys are doing lots of amazing stuff in the telehealth space, and I think that's a really tricky situation. We in paediatrics have the luxury of seeing these kids in person. I suppose it comes down for me, if I were to get a call about that, it's about risk stratification and knowing what the evidence is, and then trying to see the oral picture and what the parents' expectations are as well, and trying to navigate that. I don't think there's a clear-cut answer to that. I think, if it's also, is it just an ERT? Are we thinking, is it a lower respiratory tract infection as well? Are we worried about lower airway respiratory involvement? What's the context of the duration of illness? Yeah, I think I'd struggle if I was in your situation, but I think it's about risk stratification and seeing what the history is, and then our own comfort level as well, in terms of safety netting.
To diagnose acute otitis media, you need three things: pain, fever, and abnormal findings on exam. And you're not going to be able to have the abnormal findings on exam, but if you've got pain and fever, then I think that's helpful. And if you're in the context of a child who's had this illness before and is presenting in a similar way again, I think that's also very helpful.
We have another question along the same lines about doing a telehealth consult of a child with a cough. I'm assuming this might be around acute cough and parents, requesting antibiotics for their child's cough via a virtual consult.
I think using those simple questions that Aaron outlined really clearly, those simple signs to try and work out, does the child have, could the child have pneumonia or not? So pneumonia you can diagnose it on history and asking the parents to take some simple observations. So an acute febrile respiratory illness with tachypnea and indrawing and no wheeze potentially equals pneumonia. And I think that would be a context where antibiotics will be appropriate. The presence of wheeze is usually reassuring that it's not pneumonia and is likely to be viral. It certainly seems that in the post-COVID era, we're seeing a lot more children with nasty, complicated pneumonia. So I think we have to be a bit more careful than maybe we were in the pre-COVID era. We also have to remember that pneumonia is more common in New Zealand than in many other developed countries. So guidelines written from Europe are not necessarily completely directly applicable to the context we work in here.
Why is that, Cameron, that we're seeing worse pneumonia now than pre-COVID?
It's a really good question, Hazel. We've seen it with a number of different respiratory infections. We've seen it very sadly with pertussis last year. We had several little babies die from it. Several in 1 year, which is most uncommon, and we think is due to that period of quite intense isolation where there was no boosting of our immune systems with mild or asymptomatic pertussis infections. We think there's just been a change in the relationship between viruses and bacteria in the community. There's clearly some nasty bacterial strains that are around at present. A very nasty Group A strep strain, which has caused a lot of problems in the Northern Hemisphere and is causing great issues amongst some little children hospitalized here. We've got the legacy of a choice by Pharmac to pick an inferior conjugate pneumococcal vaccine that didn't cover all the serotypes, and then when they changed to the one that most of the rest of the world's using, they didn't institute a catch-up policy. So we've again had many children unnecessarily vulnerable to a severe and life-threatening infection. So a whole range of issues. Yeah,
we've got quite a lot of questions about managing wheeze. I think, Aaron, you mentioned in your presentation as well around using steroid in children under 12. At the moment it's used smart therapy when they're above 12. So can you just talk us through a little bit of the evidence? Is there anything coming out around using that LABA ICS combo when they're below 12?
So there is evidence for using that LABA. So essentially, if we start off with a low dose inhaled corticosteroid, the stepwise progression according to the guidelines is that then we then combine the LABA and inhaled corticosteroid and then work up on our dosing. So sorry, I hope I didn't confuse anyone by saying that so what I was trying to get at was that a LABA alone in isolation has no role in pediatric asthma because of increased rates of mortality, but actually in combination, there is evidence for that in the 5 to 12-year age group. So if you look at the algorithms, it starts off with low dose inhaled corticosteroid, then you work out with your combination inhaler, and then with that, you might consider additional Montelukast as well.
We have a question here around this swallowing issue with ICS, and is it as bad now that we have more use of spaces?
Even with spaces, it's very, very difficult for preschool age children. And you know, as everyone will also know, we can't use they can't use the breath activated devices when they're so young. So we really, you know, we really are in a tricky place in terms of trying to reduce inhaler use, and the only way we can try and do it is find other things that we can give that you know reduce the need for children to be prescribed inhalers.
We've got a question here around treating preschool wheeze, Cameron, from your part of the talk. We've got here kind of what's your advice for treating intermittent preschool wheeze in primary care if most things have shown to be of no benefit?
Taking a history to try and identify those who, you know, clearly have an atopic background with eczema and food allergy and those problems in other family members. If they are going to be effective, then you will see an effect within a month. So you can do a therapeutic trial if you're uncertain. But then, you know, trying to address other aspects of exposures that predispose to wheeze, you know, passive cigarette smoke, housing conditions, you know, and just the importance of keeping people away when your child is unwell. We get children who get you know, recurring respiratory viral infections, and they just never get a chance because they continue to be exposed to these things repeatedly.
With the Arrow trial, Cameron, for people that are working outside of those centres you mentioned on the maps, for example, working rurally, is there any opportunity to enrol children there in that trial?
Yep, no, they can be enrolled. Very happy to take referrals from anywhere. We can interview families over the phone or Zoom. We courier the study medicine out to everyone anyway. So no, very happy to do that, and we're very keen to try and make it as you know, as widely available as possible.
So when in primary care should we start to suspect bronchiectasis in a kid with a chronic cough?
Essentially, it comes down to, I think the crux of the history of that daily persistent cough is key. So a cough that doesn't go away, that is there every day, is not normal. And so then it's a matter of figuring out, is it recurrent back-to-back infections, or are we actually having sort of early signs of bronchiectasis? And if you're getting that history of persistent coughing that we've excluded all the red flags for, and we've treated as protracted bacterial bronchitis, you know, with the first course of 2 weeks of antibiotics still persistent, we've then brought in, there was a question about what antibiotic choices we use as well. So I've answered it via type. I'm not sure if others can see it, but essentially the antibiotics that we use is amoxicillin, augmentin, or cotrimoxazole is what's suggested in the guidelines. So generally, they haven't been started on amoxicillin. I start off with amoxicillin first for the first 2 weeks, and then if it's still persistent, then I might go broader with augmentin for the subsequent 2 weeks. But if it's still persistent despite then it really, we really need to look at them and sort of think about what is it, and do we need to exclude other differentials, and do we need to think early about an HRCT?
So I've got a question around antibiotics for otitis media and whether there's any difference that we should use for Māori and Pacific children, because there was a comment that the guidelines for Aboriginal children in Australia are quite different to non-Aboriginal children.
I personally haven't come across sort of variations.
So approach it the same. Cool. Some parents ask about supplements to prevent infections in children. Is there any supplements that are useful at all, if there's evidence behind that?
Vitamin D deficiency increases your risk of acute respiratory infections, and we have shown in New Zealand that vitamin D supplementation during pregnancy and infancy reduces primary healthcare visits for acute respiratory infections in the first 18 months of life. Vitamin D deficiency is widely prevalent in New Zealand. I believe all pregnant women and young children in New Zealand during winter and spring should be on vitamin D supplements. If you're going to use them to try and prevent acute respiratory infections, then they really have to be taken daily. Giving larger bolus doses more intermittently is not physiological and doesn't give you the immune benefits you get from a daily dose. And there now are Puria drops available, which are, one drop a day kind of dose, easy to give to little babies. So yeah, it remains a very neglected area of child health policy in New Zealand.
We have a question here around using nebulizers versus MDIs for treating wheeze. Are they just as effective as each other? Is one more effective than the other?
So evidence suggests that actually spacers are more effective than nebulizers. So when you look at the particulate size of what is being delivered by metered-dose inhaler versus a nebulizer, there's often the perception that the nebulizer is more effective, but actually the evidence suggests the contrary. I think part of why there might be a perception as to why the nebulizers might be more effective is that often by that point we're also usually needing to give oxygen at the same time. And actually if we give it via spacer, which is ideal, it actually gets into lower airways more. So yeah,
Cool.
short answer is spacer superior to nebulizers, but obviously in the sick kids who can't move in the air as much, then we go nebulizers.
At what age should we use peak flow monitoring?
I don't think there's an age. It's more, can the child do it?
Is there a role for intermittent Montelukast with onset of URTI-induced asthma flares?
Not as far as I'm aware. I think the evidence for Montelukast is reasonable for exercise-induced wheeze, but I don't think they've looked at, as far as I know, evidence for starting at onset of URTIs to see if that reduces severity outcomes. I think there's definitely a role for because if you look at the asthma guidelines, they do say consider Montelukast in the 1 to 4 year age group if they do fit the history, then it kind of talks you through it, but not necessarily in the acute context.
Erin, in one of your slides, you talked about having a fever of more than 5 days being, potential reason to discuss with pediatric medicine. From when I did the pediatric diploma back in the day, Cameron, we talked about Kawasaki disease, and that's not something you want to miss. Outside of that, is there any other kind of key diagnoses that we should be thinking about, or what is it about a prolonged fever, if there's no clear Kawasaki features that should be going on in a primary care clinician's mind?
I guess it comes down to what your working diagnosis is, and what the presentation is. Sometimes we do get, viruses that give you a prolonged fever, but often the worry is, are we missing something else that is, for example, a bacterial infection or an URTI that's then developed into pneumonia, and particularly if we've treated for something as well, and if we've treated it at the right dose, the right antibiotic choice, then if it's bacteria, we would generally expect to see improvement within 48 hours of treatment. And so I guess it's just a little flag thing that I always highlight to juniors, like we would expect improvement. So if we're still spiking fevers at day 5, are we missing something like a abscess, or depending what the diagnosis is, are we missing something else? And obviously then Kawasaki is one of those big ones that you don't want to miss. But it's usually if they're still remaining the same clinically, and then, they haven't deteriorated, then maybe we can adopt a watch rate approach. I think it's very case dependent but we wouldn't, a fever of greater than 5 days might make you go, oh, what's going on there? Are we missing something else in addition to that? And that's where your kind of framework for assessing a fever, working down from head to toe, and making sure you're working through the brain, eyes, ears, mouth, neck, chest, skin, bones, tummy, just to make sure there's nothing else brewing on top of that.
We sometimes use the asthma control test. There's a kind of adult and a pediatric version. Is that something you'd kind of recommend for primary care clinicians to use when we're keeping an eye on a kid with asthma in terms of being helpful?
I haven't used it. But I wonder whether it's because we're secondary based.
Yeah. Yeah.
What is it, Hazel? Is it a measure of sort of night waking and frequency of inhaler use and
so ask a good kind of 6 or 7 questions around those exact things, the asthma symptoms in the last, I think it's 2 or 4 weeks, and gives you a score. I have used it a couple of times just to have something kind of a bit more objective, and I've found it useful. But I guess
I mean, it's those interval symptoms, of night symptoms and exercise induced symptoms, and how often you're having to get an inhaler from the pharmacy are all really valuable, I think, aren't they?
Yeah, it covers all of those things. So and often when we're a bit strapped for time, it can be quite good to quickly get a lot of useful information.
Yeah, no, I think so.
Cool.
We do clarify that history, I guess, when we're looking at asthma control. So I think it's cool to know that there's a tool out there actually.
Just got another interesting one here. So if a kid does have a chronic cough, and we do go through the 2 weeks of antibiotics, as you discussed, Aaron, and then we end up doing an X-ray, which showed some potentially bronchopneumotic changes, I guess abnormal chest X-ray. Then what do we do about that?
It depends on what we're seeing in terms of the case. So I guess we would always firstly say try and do the chest X-ray when they're well. So give it at least 6 to 8 weeks following any episode of illness, so that we capture it when we're well. I think it sounds like if we've still got a chronic daily productive cough, the X-ray probably doesn't mean anything at this stage, because you would still go down the pathway of treating protracted bacterial bronchitis but you may consider, I guess, an X-ray once you've completed the course of treatment when they're well, and hopefully they haven't caught another virus or bug in the meantime. But I guess an abnormal chest X-ray would want to know about, but it's also related to the clinical context of what is the case like,
And if we do use those 2-week courses of antibiotics and potentially back to back, like you discussed again, Aaron, does it have a role in preventing bronchiectasis?
Not as far as I'm aware. It's more, I think, related to the pickup of that. Again, it comes down to history of, do we still have that chronic cough? I think it reduces, because protracted bacterial bronchitis is bacteria colonization in the airways, and so. But I don't know in relation to your question as to whether there's a preventative role.
My only other thought at the moment about prolonged cough is just be on the lookout for pertussis. I think the epidemic that started last year looks to be increasing this year, and anyone who's got an acute persistent cough, of 2 weeks or more, particularly if it's worse at night, around 1 in 5 of those people will have pertussis, and that's across the age range from 5 years upwards, and it's very tricky to diagnose in many people now because it's vaccine modified, so much more subtle, so much more of a clinical overlap with other things. So, but just be on the watch for it. I'm worried what's going to be happening over the coming months.
And I think that's where they're going through the history in terms of the red flags come through, in terms of guiding that, just making sure that we actually work through all the red flags. If excluded a cause, any other alternative causes for that cough prior to going to the antibiotics as well.
Awesome. Well, that's a lot of questions that we've gone through. So thank you so much again, Cameron and Aaron. Your presentation was excellent. The resource is great. And there's lots of clinical pearls here that we can take back into the office this coming week. So thank you so much, everyone. We'll wrap up for tonight and have a lovely rest of your evening. Mā te wā.
Te whakiatanga e, te whakiatanga e, tēnei te kāpapa ka ea, tēnei te wānanga ka ea, te mōri o te kāpapa, kei whakamoia, te mōri o te wānanga, kei whakamoia. Koea ki ranga, koea ki rara, humi e, hui e, tae ki e.
Thank you.